mode.
Hello, everyone. Sorry for the delay. We ran into the usual last-second technical issues, but we've got those resolved. So welcome to this month's webinar, and we're really excited about this particular topic. Before I go into the topic, let me introduce myself. I'm Neftali Serrano. I am the Executive Director of the Collaborative Family Healthcare Association. And we host these webinars as a way of promoting the field of integrated care and focusing on particular topics of interest, of emerging interest to the field and to our own membership. If you are not familiar with CFHA, we certainly invite you to learn more about our association. The gist of it is that we promote the field of integrated care, that is the integration of behavioral health and medicine. And our members are physicians, behavioral health professionals, payers, foundations, and just about anybody on the national scene interested in promoting integrated care as the standard of care. So we are really pleased to have our presenters today, Dr. Turgeson and Dr. Peterson, in particular focusing in on a very, very salient frontier in the field of integrated care, and that is rural primary care and adapting our integrated care models to a rural setting. Before we launch into the presentation, I also want to make you aware of another learning opportunity, and that is our annual conference that's coming up very soon in October. This is October 19th to the 21st, and it's in Houston, Texas. If you want more information about that conference, which is really the meeting place for folks in integrated care nationally each year, you can go to the website, integratedcareconference.com. That's integratedcareconference.com, and that'll give you all the information related to our conference. And our presenters will be there. They'll be participating there as well. So if you like what they have to say today, you can stop by and say hello to them there as well. So without further ado, let me introduce the presenters and then do one other business item related to your interaction during this webinar. Dr. Mary Peterson, well, Mary and I have known each other for several years now. She is the department chair at George Fox University, and she's done great work in training graduate students and early career professionals in integrated care. And George Fox has been really a leader in designing their training around that and cultivating integrated care sites. So she's well versed in the area of workforce development and also in the movements in Oregon around integrated care. She serves on the board of directors, for example, with the Oregon Psych Association. She's on the board of directors of the Regional Medical Center and is on the clinical advisory panel for the county health plan as well. Dr. Turgeson has also cut her teeth in integrated primary care, primarily at Providence Medical Group, one of the big providers in town and in the Portland area. Additionally, she's an adjunct faculty member at George Fox and a behavioral health provider, a clinician at the Yamhill County CCO. So she also has worked a great deal in the area of workforce development related to integrated care. So we have two folks who are well-versed in the topic area of integrated care and in rural settings in particular. So we're excited to have them here with us today. Your interaction with them is welcome. We have you muted, so you won't be interacting using audio, but you will have the opportunity to ask questions throughout, and they have chosen to allow you to ask questions as we go. So if you look at your control panel, the GoToWebinar control panel, at the very bottom, you have the chat section. And actually in the slide, it says the question section, but I would reference you to the section below, which is the chat section. It's a little easier to type and look at the questions there. So you can type in your message there, your question, and say, hey, what about this? and the presenters can see that and respond to that as we go. So please feel free to interact and ask questions as we go. So without further ado, I'd like to turn it over now. Actually, I think our next step is Casey Gallimore. So Casey, why don't you introduce yourself, and then we'll get to our presentation.
Okay, thank you. My name is Casey Gallimore, and I'm speaking today on behalf of the Research and Evaluation Committee. And I just very briefly want to talk to you about the Research and Evaluation track that's going to be happening at the upcoming CFHA conference. You can go on to the next slide. So just a bit of background on this track. We know that many CFHA members are interested in or need to do program evaluation, QI, and research, but may not always have the training and experience to successfully do so. So starting in 2015, at the conference, we offered this track for the first time to provide how-to lessons on how to plan, conduct research, QI, and program evaluation in real-world healthcare settings. And there was excellent feedback on this track, and so it's been repeated. And this year, I'm happy to announce that we have 10 talks in this track, and I just want to give you a bit of content that you can expect to see at the upcoming conference. So you can go on to the next slide. So the sessions for this track are going to run on both Friday and Saturday. On Friday, there's a total of 4 sessions. And the first one is listening to and collaborating with patients, a pragmatic approach to determining patient needs and interests. And this session will equip participants with specific strategies and steps for involving patients in the QI process. Also on Friday is Beyond the Veil of Numbers, introducing ethnographic tools in primary care behavioral health impact evaluation. And this session will describe how to use ethnographic methods to evaluate primary care behavioral health implementation. Next up on Friday, the primary care behavioral health model, engaging in practice-based research to assess the impact of your clinic work and move the scientific research base forward. And this is a workshop that is designed to help practices and clinicians develop strategies to improve the rigor of the local evaluation efforts, while also contributing to the science base. And then the last session on Friday is But Will It Work? How to Systematically Adapt Evidence-Based Interventions. And this is also a training session that will introduce adaptation frameworks from implementation science as used in 2 ongoing studies. And then we'll give participants the opportunity to apply these frameworks to their own practice settings. So then moving on to Saturday sessions, and there's a total of 6 sessions on Saturday, 3 in the morning, and those are listed on this slide here. The first is primary care system redesign using EHR data to evaluate impacts of primary care behavioral health implementation on anxiety, depression, emergency department visits, and patient engagement. This session will discuss the evaluation impact of primary care behavioral health implementation in 3 clinics over a 4-year period, and then offers recommendations for implementation. Also Saturday morning, testing unique clinical pathway, acceptance and commitment therapy for chronic pain in an integrated primary care setting. And this session will present a study examining the delivery of brief ACT treatment by a behavioral health consultant and provides participants with skills if they're interested in completing a similar project. And then finally, Saturday morning, some documentation to data collection, envisioning EMR patient information and clinical data. And this session will highlight efforts of an integrated F2HC to develop a comprehensive EHR data collection procedure, and then aims to demystify the process of transitioning traditionally qualitative treatment outcomes into quantitatively measurable research and treatment variables. And then Saturday is rounded out with the afternoon sessions, and there's 3 there as well. So disseminating your ideas, a conversation with the editors of Family Systems and Health. And this workshop is going to be facilitated by the co-editors of the journal and will help define strategies and tips for preparing a manuscript for publication. Next, how to use a quality framework to guide implementation and evaluation of integrated behavioral health. This is a workshop that will describe a quality framework to evaluate and then drive improvements in integrated health and guide participants in applying the framework to their own clinical settings. And then rounding out all the sessions, mind your P's and Q's, conducting QI and primary care behavioral health using the CPHQ and PDSA. And this is a session that will describe how to use the primary care behavioral health provider experience questionnaire in the context of Plan, Do, Act studies. So we're really hoping that one or more of these sessions will be of interest to you. Similar to previous years, we are offering a certificate. You complete 2 or more sessions and simply need to sign in on the attendance sheet to receive your certificate. And the last thing I want to mention is to invite anyone that's interested in the Research and Evaluation Committee to join us. We are meeting in person at the CFHA conference, and that's going to be Friday, October 20th from 7 to 8 a.m. in the morning. And then we also do have monthly conference calls that are open to everyone, and that's the first Thursday of each month, and the contact information is listed there. So I thank you for giving me a couple of minutes to talk today, and I really hope to see you guys all at CFHA. Thanks.
Great. So without further ado, Mary and Jerry.
All right. So this is Mary Peterson, and thanks for the introduction and the opportunity to do this. I'll just do the housekeeping, disclosure. We haven't had any financial relationships, although the CCO, as you'll hear later, did provide a grant to develop this pilot. Learning objectives. I am really going to focus on the first one, the importance of working with multiple stakeholders. As you might have guessed from my list of recent experiences, one of my areas, a niche, if you will, is working between systems in program development. So I'll share a little bit about how we did that in this rural pilot. Then Jerry will take the majority with understanding how to meet the needs of the different clinics. And probably most important is how we develop training resources, because like many areas, I think there's a dearth of trained providers in integrated care. And then I'll close the session by talking about how we use the relevant outcome data in order to leverage sustainability. So we'll go ahead and begin. So first, our story. We're in a rural area, as Neftali noted. We have approximately 30,000 of our 90,000 residents in Yamhill County eligible and enrolled in the Medicaid plan. I will say with the Affordable Care Act, we had an increase of about 30%. So we're ultimately at 30,000, but you can imagine an increase of 30%, our clinics were fairly overwhelmed in the beginning. They had a conceptual agreement or desire to implement behavioral health, but in our area, we're strapped for resources. So fiscal sustainability was an issue, namely for our clinics, our providers, and ultimately the health plan. So in program development, how I typically approach this is determining the stakeholder needs. And while it's easy to say, oh, well, yeah, great, we all do that, for us, the needs are very different for our different stakeholders. And so it is all about relationship and developing the conversation. So the very first stakeholder we started with was our health care plan. They were the ones who felt, quite frankly, fairly overwhelmed with the increase in their population. So that was the first one that we started with and had actually a series of conversations. The second group we started with was our providers, or we went to as our providers. Again, if we are going to implement something in their clinics, they're overwhelmed, right? So we needed to find out what are their needs and understand that before we even went to the program development. And then finally, because we're rural, we have access to our patients. We have focus group with patients. We have community members on our various boards. And so we intentionally had conversations with patients about what their needs are. After that, we stepped back and we sorted through the information. And the specific needs that were identified included really the triple aim for our health plan, not surprising. The other thing to know in a rural area that is short on money is how they were planning on their fiscal sustainability. And one of the things related to the triple aim in our area was incentive metrics. And so, again, this is working with the needs of the stakeholders. They were motivated to reach the incentive metrics identified by Oregon Health Authority because that meant that they would get a kickback of a lot of money that then would help them expand programs. So it was really important for us to hear not only the triple aim globally, but specifically within that, was there any specific need that they wanted us to address? The needs of the providers, help with these high-need patients. As I said, with an increase of 30% and the enormous health disparities in rural areas, they were getting people coming into their clinics who hadn't seen a primary care provider in a decade. And so all of those needs were just, waiting to be met, and it was fairly overwhelming. So we had to keep that in mind. They wanted help with these very high-need, complex patients. The patients or the residents, over and over again, what Jerry and I heard was access, access, access. And anybody who works in rural health, I think there's access problems everywhere, but in our area, so much of it was around typical barriers in rural areas. They didn't have transportation, right? They didn't have any way to go. They didn't have ways to fill prescriptions. They couldn't access specialty providers. So what we had to do is figure out ways to increase access, and there's no better way, obviously, than integrated care. So we addressed this by looking at what resources, from a program evaluation standpoint, right? What resources did we need to develop in order to meet those needs? And clearly it was workforce development. So what we did is apply for an innovation grant. And again, we only knew what to put in that grant because we had those conversations. And so basically we stepped back and we said, what resources can we access across systems? So we have an educational institution, ours. We also have program leadership. Jerry had already started at Providence. We also link, and we can talk more about this at another time, we link to the ED system. So that was another part that we could roll in because our grant was accepted largely because we activated about 4 different stakeholder systems in the county. So that's the systems picture, the big picture in summary. It is really focusing on working with identifying and attempting to meet the stakeholder needs. Now I'll transition to Jerry, who will talk about how the nuts and bolts of how we met those needs.
Absolutely. So part of our writing of the innovation grant, we had 3 clinics that were really actively interested in being involved as part of our TCO and taking care of these high-risk Medicaid members. So we had 2 private clinics, and then we had 1 SQHC. So we had some different clinic needs just as far as clinic presentation goes. But roughly all of those Oregon Health Plan Medicaid patients were divvied up between these three clinics. With having 3 different clinics in the development of this new project, and given the financial limitations within Yamhill County and the scarcity of resources, we really wanted to be good stewards of our funds and make sure that we could develop and create a program that was going to be fiscally sustainable and then also meet all of those identified needs that we outlined during our information gathering process. With that, we became very aware of the significant limitations in providers who have training and how to function effectively within an integrated primary care setting. We were concerned that if we just took people who were great providers with great clinical skills but hadn't been in this model before and placed them in the setting, that we would have mission drift and model drift with kind of transitioning back to what they know and what they do well and ultimately ending up with a co-located model inside primary care, which would not hit those all-important access of fiscal sustainability, provider access and satisfaction, and patient access. We also wanted to make sure that we were able to set our providers up well so that they wouldn't have such a sense of culture shock transitioning into that primary care setting. So looking at how to make this happen, we decided that we really needed to create a pretty comprehensive training program for these providers prior to placing them in the primary care setting. So we did some program development and created a pretty intensive training process that involves a 40-hour boot camp, in-clinic shadowing, and then some ongoing consultation and support meetings. So I'm going to talk a little bit and show you guys what our training process looks like that we've developed for providers. So the first piece that we do is our boot camp, and this is a sample schedule. So it's a pretty intensive 40-hour training. This is the iteration that is actually currently taking place. We've done this now multiple years in a row for providers. we have the training broken down into 4 distinct modules that provide a pretty comprehensive overview. So the first module looks at overview, the second is interventions, the third is assessment, and fourth is community integration. And I'll talk a little bit more about those modules in just a minute. Our goal, though, is also to have a variety of voices and some subject matter experts that come in and talk. I am very capable of talking for 4 days straight, but it's really nice to have a variety of experts who can come in and share their expertise and really lend some of that variety and perspective. We also aim to have a multidisciplinary approach with this. So we've had MDs who have helped to do instruction and teaching, and then we have also had a clinical pharmacist who's part of our training process. And then the trainings themselves are multidisciplinary. So we have psychologists who attend, social workers, LPCs, and then we also had a variety of physicians and pediatricians who've attended, which has been really great from that diversity in training to make sure that everybody understands the model well. So this is a really typical schedule that we put together. The first model, as I mentioned, looks at giving the providers a pretty comprehensive overview of what is integrated primary care. We start with an overview of the different models of primary care and how it can be done well in a variety of ways, and then really bring the providers into a focus on the PCBH model as outlined by Robinson and Reeder. We really want a focused, integrative, accessible approach that has that warm handoff, brief visits, high level of accessibility, and a high level of provider support. Once we give them an overview of that model, we transition into some pretty specific overview on how a behavioral health provider functions well within their role. We look at scope of responsibilities, engagement in team-based care, and really the wide variety of activities that are expected of a behavioral health provider and how they can achieve all of those in a sustainable manner. We also spend a fair amount of time just looking at logistics, so the fundamental skills that someone would need to know to start well. So what does billing look like in a primary care setting? When do you bill for a visit versus when is it a warm handoff? How do you do a warm handoff in the middle of a busy clinic day to step out of one room with a patient and into another room and then transition back well? We talk about charting and record keeping. I think a lot of my providers who come in who've not done integrated care before, HIPAA and confidentiality is a huge question that comes up. So we spend a fair amount of time talking about that and how do we protect patient confidentiality, but really keeping an eye towards team-based care and communicating what is really relevant for the treatment to take good care of these patients. And then we move into talking about the culture of primary care, particularly for our providers who haven't done integrated care before. Pacing is a whole new world for them. So we look at brief skill development. How do you do an effective 60-second consult with a physician? How do you do a brief visit? What does a brief intervention look like? How do you pace and scale a visit so that you can be effective in 20 minutes and maintain a rapid pace schedule? And then we start that discussion around a biopsychosocial model of care and looking at the relationship between contextual factors, our population that we're working to serve, and how that impacts their health status and integration with their health. So I have a clip here from the training of this first module. So I'm going to show you guys just kind of a small, this is a little 3 or 4 minute snippet of what kind of this first module looks like. So hopefully you guys can hear this.
I'm sorry, Jerry, are we supposed to be hearing something because I'm not getting anything on my end?
Yeah, oh, is the volume not coming through? Otherwise. Okay. Oh, shoot. Well, I will talk you through. So these are a few slides. Unfortunately, it sounds like maybe the volume's not going to come through. So this is to start looking at we have an instructor teaching on integrated and coordinated care models. And so what different models of care look like, providing some foundational understanding for our providers, and then moving them into an understanding of what a truly integrated approach looks like. So, and I'm sorry the volume's not coming through for you guys.
Okay, when we post it, it'll come.
Yeah, hopefully when we post it, you guys can actually hear the volume of the instructors that's taking place. So after that first day of a lot of just background and foundational skills and knowledge building, we move into the second module, which is then actually looking at how do we do treatment well from a biopsychosocial perspective in integrated primary care. So we start with how do you do a good brief functional assessment of patient and patient presentation in a brief setting to really capture what's happening and to then develop a targeted treatment plan. We give some brief overview on stages of change and motivational interviewing and just really practical skills that providers can utilize, and then transition into a pretty comprehensive overview of how to do brief interventions for specific medical conditions that come up within a primary care setting. So we provide some general overview of common physical health presentations that a behavioral health provider would be expected to see within a primary care setting. We give them medical language, common abbreviations, like general labs that they should be able to know and understand as part of their patient care, and then help them identify what their role is as a member of the treatment team in effectively addressing those various medical conditions. So some of the conditions that we cover include weight management, hypertension, headaches, persistent pain, asthma, smoking cessation. We do talk about those patients who maybe have a somatization or a health anxiety component to their presentation. And with that, our goal then really becomes how do we scale this and shift this so that you can do an effective intervention within a 15 to 30-minute office visit. We give really practical interventions and tools that they can do, and then actually role play and practice brief interventions and utilizing those tools so that they can really walk into the clinic day one with a set of tools and knowledge base that allows them to be able to jump right in and be able to walk into a room and effectively engage with a person who has diabetes on day one and feel like they have a foundational skill set to get started. We also do an overview of common mental health presentations within a primary care setting and give some understanding around how do we scale those good clinical skills that perhaps they learned in graduate school into a brief primary care approach. What does treating depression from a brief intervention standpoint look like? How do we scale that within primary care? And helping to give them the confidence to really keep those patients within a primary care setting who need to be there and not up the level of care or refer patients out too quickly. Particularly being in a rural setting, we don't have a lot of options for referring patients out. And so access and availability and being able to be seen and treated right within their primary care setting is really important to our patient population. We also talk a lot about psychoeducation within a primary care setting and how to help our providers feel confident to provide psychoeducation on medical-based conditions, as well as talking about how to think flexibly and provide a variety of services to help with that accessibility and access. So we work a lot around how do we do support groups, but then also how do we help do group medical visits. The group medical visits are in particular a win-win because there's a high level of access for the behavioral health providers. They also help our medical teams have a high level of access because we're able to see and service 6 or 8 or 10 patients with diabetes all in one room with one visit at the same time, which we found to be really powerful for both the patients and the providers. And so it's a great satisfaction piece. I'm going to guess that you guys probably can't hear this video either. So I have, when you get this PowerPoint, the next slides are of Dr. Laura Fisk. She is the clinical psychologist who runs the persistent pain program for our local CCO. So she comes in kind of as part of this discussion and does some talk around persistent pain and pain-related interventions. So these are slides from her part of that module tool to training, and you guys can hear kind of what sorts of information and education she gives the behavioral health providers moving into an intervention standpoint. Our third module talks a lot about assessment and screeners. So we talk about open source and efficient tools that can be helpful and really help our providers understand a comprehensive approach to population-based care. So assessments can be a really important part of doing broad screening, a population-based focus, and gathering a lot of rich information in a very efficient way. And so we give them a variety of different assessments, a pretty comprehensive assessment manual, and then do a lot of hands-on training with what are different assessments that are doable and usable that they can effectively do, and then actually help them. A lot of providers are familiar with some of these. A lot of the screeners are very new, so we actually practice giving the screener, scoring it, talking about how you would write it up within the medical record, and then how you would provide feedback to the physician. The last module that we do looks at program development and community integration. So part of being in a rural area, access and resources, again, I think we've said this a few times, but it's so limited that we really do have to approach our patients' care from a community-based standpoint. We really do need to look and see what resources do I have in the community? How can I help support this patient's need? Knowing that we as a primary care can't do everything, and simultaneously, we can't just refer them to a long-term mental health provider because those really don't exist. So we really look, so there's two parts with this community piece. We talk about community within the primary care setting and developing really effective, strong working relationships with members of the interdisciplinary team, and how that team-based approach to care becomes really important, and the behavioral health provider's role within the team. We also talk about then, like I said, the community awareness and how do we integrate into our local community. So what resources are available to patients? How would they go about accessing those resources? So when I started here in Newburgh, it was really helpful for me to figure out where are my local food banks at? What are resources? What church and faith-based organizations have like soccer camps and programs and scholarships, so that I can help think about creative and flexible ways to get my families active and moving and integrated. And isolation is huge in the rural area. We don't have a lot of transportation. In fact, we have really no public transportation. So for patients who are limited in their resources and transportation, how can we help them get out and integrate into their community and really think about that holistic health in a positive way? Joy Malden is a psychologist that the next few slides have her kind of take on this community piece. And she talks a lot about how she spent a lot of time exploring community resources where her clinic was at, and she learned that there were 71 parks within the Salem area where her clinic is located. And so she spends a lot of time with families as far as getting them out and active, talking about these 71 free parks that they can go to and access as a local community resource. We also then talk about, kind of from that systemic standpoint, how do we manage crises and work collaboratively with the extended system? So Mary mentioned that we work very closely with our emergency departments. Because we are rural, we know these patients very well. And so there's a really fluid relationship between when a patient unfortunately has to go to the emergency department, the assessments that are done, the triage that takes place, and then really working to very quickly integrate them back into their primary care clinics. So we've been able to develop a system of relationships so that if one of my patients shows up at 2 in the morning with a crisis, that person is screened and assessed and then put back on my schedule for a behavioral health visit the following day, so that we're really able to fluidly move those patients back into the right level of care and use our behavioral health providers as a key access point in supporting the patients where they need to be receiving their care in the best possible way. So I am gonna move through the next few slides. This is, again, sorry, a video you guys can't hear right now. In addition to the larger modules that we do from training, we have some additional selected topics that we do. So pediatric behavioral health care is a key area that we really try to focus on, both from an early intervention standpoint, and then we have all of our clinics service and provide supports for pediatric patients. We spend a lot of time talking about persistent pain and pain management, in particular with the opioid epidemics that we are experiencing, and how behavioral health can be a component of persistent pain management. And then working with those patients who maybe have an opioid use disorder, heroin, and how to get them into the right level of care and support them from a chronic management standpoint within the clinic. We talk a lot about crisis and risk assessment. How do you do a comprehensive and thorough crisis evaluation within primary care? When do you decide to increase level of support versus keeping those patients? And then group medical visits, which have been really popular and a great way, again, to get access and support for our patients. We also have some additional providers come in. So we have a clinical pharmacist who comes in and does a piece on awareness around psychotropic medication and common side effects to just help increase that knowledge base to make sure that our providers are able to at least start to have fluid conversations around medication and side effects and be a positive consultative support for the primary care physicians within the clinic. So we really want people to be well-resourced and able to leave the boot camp feeling like they have good skills and tools. So in addition to all of the education and support, we have a manual that we put together. It's gone through a lot of versions and a lot of reiterations, but it's a pretty comprehensive, this is primary care, this is what your role is, this is what it looks like. And then the second half has some medical sheets that were developed. Myself and my medical director sat down and put together like kind of a crash course in medical diagnoses with symptoms presentation, common labs you would want to look for, and then brief interventions for each of those, so that if you have someone for the first time, you've never seen someone with diabetes, you can flip right to that section. It will give you what to look for, what are some ideas for intervention, so you can really walk into the room knowing how to make the most of that 20-minute visit. We also have, I mentioned the assessment manual, so all of those population-based screeners, free access resources that they get taught and trained on during the boot camp, we give them copies so that they don't have to go online to try to find them. Everything is right there, easily accessible, that they can get started. We also have, so this is a document that Julia Oyemaja put together that is, again, just kind of her perspective on that first visit and how to use that 20 to 30 minutes well, and what sorts of things that could be assessed, managed, and done within that brief 30-minute contact. So we really try to provide a lot of voices, a lot of resources to make sure that our providers can be as successful as possible. Once our providers have completed the 40 hours of boot camp, we do an intensive 40+ hours of in-clinic support that we spread across 2 weeks. This has been, I think, one of the most valuable things. So they have this great foundation from boot camp, and then I get to go and be with them in the clinic and actually help them like put it together in a practical sense. So I go and I meet with medical directors, I meet with clinic leaders, I help to train their providers, and then I actually sit with the behavioral health provider in their clinic. I shadow them through visits. I give real-time, in-the-moment feedback on how can we make this work and how can you excel at your role as a behavioral health provider. It's a great opportunity to actually put that practice into action. And I think I've gotten a lot of feedback from our providers that this has been one of the most helpful things from a confidence building standpoint, as well as just helping them settle and sink into that role and feel like they can be really effective with what it is that they're doing. So this has been a huge value add from a training standpoint, that we've done it with all levels, but even I've had a couple of long-term 10-year licensed psychologists that this has been by far one of the most helpful things, with having a really practical, in the trenches, startup support. The other thing that this lets us do is it helps me help them tailor the kind of the base model that we gave to their specific clinic need. So we really have an eye for adherence to the model. So we monitor things like number of contacts per day, their reach into their clinic, but we also understand that each clinic has a very different culture. So we have some cultures, we have that one clinic that's an SQHC, we have another clinic that's very tech savvy and high tech in their approach, and they really want their behavioral health provider to be using technology as part of their interventions. And so we've been able to then take that model while looking at the kind of the non-negotiables, if you will, of reach and access, but then also help them tailor their approach so that they're really being able to jive with their clinics and their clinic's culture to best support those providers and those patients where they're at. So it's been a really nice fluid. We're not trying to just cookie cutter a model into every single clinic. We're saying this is the foundation you need, and then let's really make sure we're meeting the culture of your clinic. That's further helped facilitated through ongoing consultation meetings. So we started with weekly meetings during the first, with our initial core group, we had weekly meetings for the first several months, just really touching in after we'd finished the shadowing, just kind of that in the moment, quick feedback so that they could continue to tweak and adjust. And we've since now tapered out to monthly consultation meetings. So we still meet as a group. Every month we talk about practice dynamics, model adherence, basic information on what are appropriate interventions, how to support, kind of help triage clinic concerns that come up. And then for the first 2 years for each of these providers, I continued to do regular in-clinic shadowing just to keep an eyes-on approach to make sure that they were feeling confident, the clinic was feeling confident, and that our CCO patients were really getting the support that they needed. So it's been a really great training experience to have everything up and running in this way. So, and then we'll talk just a little bit about measuring outcome from that financial piece.
Okay, so this is back to Mary. But before we go into outcome, I do have to give a shout out to the benefit of embedding training in a community area. And I'll give you an example. So, 6 months into it, there was a launch. One of the providers was in a clinic, and the clinic manager, because again, I have a relationship with these people over years, he calls me, his name's Dennis, he calls me and he says, Mary, this is not working. He said, can you send Jerry in? Which is great because again, he built a relationship with her. And so from our consultation training model, we're very cognizant that it's not a one and done, but it's this ongoing access and support. So I really love the fact that Dennis knew he could pick up the phone and call me. We could link Jerry in, and she had a relationship already with this behavioral health provider and then could come alongside to tweak and to help her improve the program. So again, it's that collaborative piece, and the in-clinic shadowing isn't disciplinary in nature, it's training, and that's our frame. We're education and training. So nobody is going to get in trouble, there's no report to supervisor. It's collaborative, and I think that we really lean into that ethos. Okay, so measuring outcome. You know, I should check in. I think we're talking quickly because we have a lot to cover. Neftali, is this moving too fast?
I think you guys are doing an awesome job. It's great.
All right, so here we go, on to outcome. So measuring outcome is critically important in our area, obviously, because we're responsible for the deliverables. We're responsible for good stewardship of the money they invested in us. So what we looked at in measuring outcome, oh, Jerry, wait a minute, what are we doing? What are we doing? Very good. Okay, so the first thing that we used in measuring outcome was claims data. And I'll show you why later. There's linkages that you'll see. But basically, I needed something that I could use the EHR to pull. And so it was just a really important way to access objective data. Okay, here we go. There? Okay, so the first thing, if you remember, if we go back to those identified stakeholder needs, the need that the patients expressed was access. So the results that we looked at here was reach. And if you can see, the results are clear. We did pretty well in some clinics and really quite dismally in other clinics. So that's the one thing about identifying the patient need and then pulling outcome data that directly addresses that need. So while we could feel grand about Clinic C, we realized, boy, we have work to do in Clinic A. So again, it's identifying the right outcome variables because then we can do something about it. Okay, the next one. There we go. All right, there's a couple important things among all these numbers that I think are relevant in a rural setting. So if we look at, what I want to draw your attention to is the link between inpatient specialty. If you see, we showed nice reduction in claims overall. Yeah, life is grand. But we want to know why. We want to know, how do these things link together? Because again, it's not an isolated variable or an isolated deliverable. We're working across systems, right? So inpatient specialty, which is basically psychiatric hospitalization for these medical claims data, down about 28%. That is great. So then what I do, right, is say, why? What did we leverage in the system, knowingly or unknowingly, to lead to that? Well, look at emergency department, right? So there was a 37% reduction in emergency department visits. Well, these two are linked because half of the inpatient hospitalizations come out of the emergency department. We provide those assessments, so we know that. Okay, so that was one thing that really worked as we looked across systems and understanding it. Now, sure, it's a reach. Did contact with the BHC lead to reduced ED, which then led to reduced inpatient? Well, that's a leap, but it's a leap worth considering. And I can only consider it because I can look at the data across these different areas. Okay, so health plan, they were delighted with that. So we've addressed the need of the patient. We're looking at the need of the health plan. Wait a minute, here we go. We're working on Jerry's computer. Life is good, except for I haven't used it as much. Okay, so then I talked about trying to link data together and what does it tell us about our program and what we need to do. So if you remember from the slide about reach, Clinic A had reach around 30%. Look at that reduction in claims. Flat, bonk, not affected at, well, really, I shouldn't say at all, but really not at all. So again, I don't have causal data that the low reach impacted the low claims data, the expected reduction in claims data. But if you look at this trend, so look over here, Clinic C, 47% reduction in claims data. The health plan went through the roof. They loved that. Is there a correlation between the 47% reduction in claims and the almost 8% reach? Well, of course, it's not causal. And believe me, I ran the data trying to get significance, and there wasn't. But it suggests a trend. And that's what I think is really important for us to look at in rural areas. How do these things cross systems? How do the different outcome data, how can these data inform what we're doing in a larger picture, larger systems approach? Okay, so we looked a lot at health plan, outcome, expected outcome. We met that goal, obviously. Then we looked at the need of the patients. We did so-so, but learned how we can improve. The providers, as I mentioned, that we wanted to collect provider data and respond to that. We had great outcomes on provider satisfaction, but I'm not really including that because we've all done so much provider satisfaction. It's not really unique to a rural area. All right, so I will say that with these data, it really showed the effectiveness of integrated care, right? And you saw it from the health plan, you saw it from the patient perspective, reduction in services, etc. Now, I still had a problem though, because the clinic managers said, Mary, these are great data, but we really don't care that much if there's a reduction in claims data. That's the health plan's shtick. That's not mine, because I have a salary that you're asking me to cover as part of my overhead, okay? So, the behavioral health provider with benefits and everything else, costs well over $100,000. And I don't know if any of you have tried to do the fee-for-service thing, but that really does not work in our area. It's a small percentage for overhead and costs. So in meeting with the clinic managers and hearing that pretty consistently, yes, they love the patient access and there was patient satisfaction surveys. They love the provider surveys. Maybe I could have sold it based on that. But I went back to the health plan administrator And I said, all right, Seamus, this is what we have. I've got clear data that show this is good. This is good for the health plan. This is good for all these reasons. And I have clinic managers that say to me, well, yeah, that's great for the health plan, but not so great for me because I'm really struggling with all these new covered lives, from a budgetary standpoint. So because he saw the value of that, and really the board of directors, what he did from a system standpoint, there's a global payment model that we use. He carved out per member per month for behavioral health services in the clinic. So what that means is for Clinic A, it had 6,000 covered lives. The health plan built in a $3 per member per month part of the fee structure. So they said with global payment, part of what you need to cover, and this is how it's broken down, is if you have a behavioral health provider on board, we will give you $3 PMPM because we know the value of that. And clearly, we demonstrated the value of that. So for the 6,000 covered lives, if you extrapolate it over the year, that's over $200,000 the clinic will get for having behavioral health services. So that piece allowed us to go back into that clinic and say, look, the health plan is invested and this is why. So let's figure out what's working. Let's figure out what processes we can put in place to increase reach, to meet more of the needs of the patients. And then we moved into all kinds of things like chart scrubbing and other process variables that could contribute to the reach. And so really that addressed the concerns of my clinic managers because they liked behavioral health, their providers liked it, their patients liked it, and if it was going to be covered by the health plan, then they were on board. So I guess from a systems perspective, from my perspective, the critical piece is meeting with the different stakeholders, understanding what the needs are, choosing outcome variables that will address those needs, and really more, I don't want to say more, but very important to me is it will provide me the data that I need for sustainability because I was invested in having this a long-term sustainable program. So that is the outcome piece. So hopefully we met the objectives with talking about how we started, how Jerry worked with building this training model, including this ongoing relationship with the clinic, and then I followed up with how we assess outcome to lead to sustainability. So we'd like to open it for questions. Otherwise, we appreciate the opportunity to present. Okay, we'll take that as a good sign. So again, thanks for taking the time today, and Neftali, thank you particularly for inviting us to participate in this, and we'll see you at the conference.
Thanks, everyone. This recording of this webinar and resources will be posted on the website in a couple of days. Have a good one.
Thanks.